Okay, can you see my presentation now?
Yes, yes, we can see your presentation now.
It's not easy to make a presentation when you can see and hear the audience. So with your permission, I will turn my camera on. Thanks to the conference, I was able to see the previous speaker, Olga Kravets. I hadn't seen her in ages. Hello, Olga, and hello, everybody. First of all, I'd like to thank the organizers for the invitation to speak at this conference. I'm very proud of it. I also want to note that I'm not an expert in the treatment of peritoneal inclusive cyst, and the aim of my presentation is to get your opinion on how you treat this rare disease. In the beginning, let's figure out what we know about this disease. The etiology and pathogenesis remain elusive. However, we know that this disease is of reproductive age women with a history of abdominal or pelvic surgeries or inflammation. Evidence suggests that hormone shifts influence the disease course. Management options range from observation to surgical resection. Cure is thought to be achievable with surgical resection only. However, given the overall benign nature of this disease, conservative management options can be considered and treatment can be individually tailored. We have various treatment options. For example, observation with serial imaging is a feasible management option for asymptomatic patients with incidentally discovered peritoneal inclusion cyst. But if there is any suspicion of malignancy, a biopsy is recommended, of course. Surgical treatment is the most commonly used method of treatment, but there is no standard operation. This can be cyst excision, total hysterectomy, bilateral salpingo-oophorectomy, appendectomy, or omentectomy can be performed depending on organ damage into differential diagnosis or findings during surgery. The surgical approach can be by laparoscopy or laparotomy. Definitive treatment is defined as a complete resection of all macroscopically visible cyst walls. However, despite extensive surgical resection and surgical castration, peritoneal inclusion cysts have an estimated recurrence rate of 50% in different periods between 6 months to 20 years. The presence of estrogen or progesterone receptors on cyst walls supposes a role of hormonal management. Peritoneal inclusion cysts have been observed to spontaneously regress in menopause. So combined hormonal oral contraceptive may decrease or stabilize the size of the cyst and control associated symptoms. There is a description of isolated cases of successful use of tamoxifen, megestrol, or leprolide in the treatment of peritoneal cyst. Aspiration. Aspiration of fluid form cyst is a diagnostic and therapeutic method to eliminate system. However, it is temporary and is not widely used. Aspiration can be combined with the use of oral contraceptives. Sclerotherapy is the use of an intracystic catheter to instill either 95% ethanol or 10% provident iodine within the cyst and breaks up thin internal septum. It is unclear what volume is required on duration time needed in contact with the cyst wall to have an effect. As you see, these methods are not also standards, and there are case series evaluating the use of sclerotherapy for management of this disease. And the last one is chemotherapy. This method is being used as a last effort in patients that have undergone multiple surgical resection, but continue to have persistent symptomatic disease. In 1999, there was the first trial of continuous hyperthermic peritoneal perfusion. The patient underwent surgical exploration and debulking followed by 19-minute hyperthermic intraperitoneal infusion of cisplatin. All patients in this trial had malignant peritoneal mesothelioma, and only one had peritoneal inclusion cyst. This patient was followed for 31 months without any evidence of disease progression. In 2003, other authors advocate surgical resection immediately followed by one dose of cisplatin doxorubicin combination, hyperthermic intraperitoneal chemotherapy, and subsequent intraperitoneal Taxol chemotherapy for peritoneal inclusion cyst. They reported this regime was well tolerated with no evidence of disease at 69 months. I want to present a case when we observe an aggressive course of the disease, which was expressed in early and repeated relapses. A 30 years old woman in October 2017 went to a gynecologist with complaints of abdominal pains lasting about a month, general weakness, and fever. Ultrasound examination revealed free fluid in the pelvic cavity, cyst of the right ovary, and tubo-ovarian formation of the left appendages. Other organs and systems were without pathology. Moderate leukocyturia, microhematuria, and pronounced increase in fibrinogen up to 10 norms were noted. The patient received antibacterial treatment without any effect. Then the patient underwent a laparotomy and surgical treatment. On the basis of immunohistochemical examination, the diagnosis of peritoneal inclusive cyst was confirmed. Unfortunately, the operation was performed in another hospital, and I can't show CT scan before the operation. Immunohistochemical staining of peritoneal inclusive cyst is positive for mesothelial markers, vimentin, calretinin, and AE1 and A3, and negative for endothelial markers, factor 8, CD31, and 34. So after 5 months, in April and 2018, the disease progression was noted. It was a thickening of the peritoneum along the right lateral canal, the appearance of low density nodes along the peritoneum under the liver left lobe. The second operation was performed. Now it was a total hysterectomy, a large omentum extirpation, resection of the small omentum, peritonectomy of the lateral canals. This time, the time to progression was only 4 months. It's horrible, of course, only 4 months and the second relapse. There were massive formation of a cystic solid structure in the subhepatic space, as well as lesions of lymph nodes in the cardiodiaphragmatic sinus were on the right and left. Mesenteric and inguinal lymph nodes were on both sides. Now we have performed cytoreductive surgery with HIPEC. The time to progression was 7 months, and in May 2019, a relapse of the disease was confirmed again. Now we're faced with an extremely difficult choice. I want you to imagine this situation. Surgeons cannot operate on her stomach anymore. Radiologist cannot radiate the entire abdominal cavity. A young woman is sitting in front of me and asking for help,
Слышала изучинская.
but we have no idea what to do.
Я скоро буду выступать на...
Since our oncological center has great experience in the treatment of malignant peritoneal mesothelioma, we decided to start intravenous chemotherapy. And the patient received 5 courses of gemcitabine with cisplatin. After 3 courses of treatment, there was a positive dynamics, normalization of blood disorders, and no symptoms of disease. But after the start of chemotherapy, we faced new questions. How to evaluate the effect? Can we use RECIST 1 and 1? I don't know, and I'm not sure because it is not even a tumor. How many courses of chemotherapy do we need? Nobody knows. And we decided to stop after 5 courses. Who should treat this patient with this disease? General practitioner, gynecologist, abdominal surgeon, or oncologist? We decided that oncologist. A year later, we registered the disease progression again and started chemotherapy with the same combination. 10 months have passed since the completion of chemotherapy, and there are no signs of cyst growth. In conclusion, I want to say that peritoneal inclusion cysts remain a rare and little studied disease. There is no convincing data in the literature on the feasibility and proven effectiveness of system chemotherapy for this rare disease. Our patient continues to be monitored, and the time of observation of the patient from the moment of diagnosis is more than 4 years. And I still don't know which treatment method will be the best for her. Thank you for your attention.
Any question from audience?